Our next speaker is going to be speaking about recent breakthroughs in liver disease. And this is Dr. Richard Kalman. He is a transplant hepatologist at Einstein Healthcare. He graduated from Tufts and did much of his training in Boston and is now down in Philadelphia. He runs the liver tumor program there at Einstein, and he manages a multidisciplinary liver tumor conference and clinic. He's also interested not only in clinical care, but in research, and does research in liver cancer, telemedicine, and palliative care. So thank you, Dr. Kalman, for joining us today.
Thank you so much for the invitation. And I guess was told to include a couple of different topics in sort of my discussion today. So in addition to recent breakthroughs and hope on the horizon, I was asked to touch a little bit on care for the liver transplant patients. And, we do know that some patients who have liver cancer will go on to liver transplant, which in and of itself is a very overwhelming process, but I'll do my best to sort of go over some of those topics over the course of the next 10 or 15 minutes. So, it's been a really important last couple of years for the management of patients with liver cancer. And specifically, I'm referring to patients with hepatocellular carcinoma. And so if we go back to 2007, just, 14, short years ago, we really only had one medication for people with advanced liver cancer. And that was an oral medication called sorafenib. It was a medicine that, did maybe extend survival for a couple of months. But although it was oral, was associated with a lot of side effects. And then it really wasn't for about 10 years that we didn't really have anything else in our toolbox. Then in 2017, we were granted 2 second-line treatments that we were able to start using. Another oral agent called regorafenib, and the first immunotherapy, which I know has been discussed for hepatocellular carcinoma, the infusion nivolumab. And now, where we stand in 2021, I would argue we have a very clear first-line combination therapy that involves immunotherapy, which has been, really very successful for some patients. We find that the tumor just melts away, and maybe even more importantly, in about 75% of patients, the tumor just stops growing on this combination therapy with atezolizumab and bevacizumab. So that for us is now in 2021 very much the standard of care. In second line, I would argue there's probably, maybe 3 kind of agents, 2 oral agents and another infusion. And then as sort of third line, we have an additional 4 agents. So if we go back to where we are just a couple of years ago, where we had only really one option, there is a lot of hope on the horizon because we have so many more things that are available for our patients. But I want to take even a step back. And I think something that's important to recognize is that, when we talk about liver cancer, unfortunately, less than half of patients who are diagnosed with liver cancer will be caught at an early stage. So I think it's worthwhile talking a little bit about what's involved in trying to detect liver cancer early. And in fact, there is some new hope on the horizon here too. So for patients who are at risk for developing liver cancer, namely those who have chronic liver disease, most often patients who have cirrhosis, we're suggesting that these patients get a ultrasound every 6 months. And for most people, it's recommended that they get a blood test with a tumor marker called an alpha fetoprotein, or AFP. And while that might not sound overwhelming, it's very hard for patients to have to go through an ultrasound every 6 months. And for many of these patients, that this is lifelong. And in fact, the vast majority of patients will, get these ultrasounds and actually not really derive any benefit from them. And why do I say that? I say that because most patients, thankfully, with chronic liver disease will not get liver cancer in their lifetime. So probably more than 2/3 of patients will not. And then there will be some false positives that come up too. Patients will get a scary call from their doctor about a possible spot that was found on an ultrasound. Maybe they even go on to require a liver biopsy to sort of figure out what's going on and go through the risks of that, and all for potentially not finding anything that's really of note. So one of the things that I think we're really excited about are some different tests that will hopefully allow us to pick up on liver cancers early when they're most treatable. And there are some blood tests that are coming out in the future that we hope will be, better sort of markers for patients who are at risk for liver cancer, and maybe obviate the need for ultrasounds every 6 months for a lifetime for many of these of our patients. And then I think the other challenge that we have is trying to engage patients in such a way that we're able to get their screening done on regular timeframes. And what that means for some people is having to take an additional day off of work to get their ultrasound, having to have somebody maybe take them to the hospital to get this done, and then just remembering to do it. So there are some simple things that are being looked into to hopefully improve really compliance with getting these screening tests done. And right now we're seeing that probably less than 25% of patients who need to be getting screened for liver cancer are getting regular screening. So I do think there's hope on the horizon for doing a better job there too. And then, in terms of the treatment, I think that we're going to see several aspects in the future that will improve. So, if we think about treatment for patients that have very localized disease, small tumors that we would hope would be curable. Right now, what we're doing is that patients are either being considered for surgical resection if they're a candidate for that, or localized therapy, which I know has been discussed earlier today, either instilling some chemotherapy into that portion of the liver or some radiation. And that's generally kind of all that we do. But I think that now that immunotherapy is so much becoming the standard of care, it seems that we're going to probably come to a point where we can maybe combine the immunotherapy agents along with these other localized treatments to maybe improve outcomes for patients. Because depending on the size of the tumor and the treatment that's involved, maybe upwards of 50 to 60% of patients will have a recurrent tumor in their lifetime. And so anything that we can do to decrease that risk would certainly be a good thing. And I know that there are several trials ongoing. We were involved with one at Einstein where we're going to be looking at combining localized therapy with these immunotherapies. And then for patients who have more advanced disease, I think something that our expectation will be is that we'll be doing more personalized approaches. And that sort of brings me up to another interesting topic here. And one of the things that actually made me most interested in liver cancer when I was a trainee was that it's one of the few cancers that often can be diagnosed without a biopsy, just based on imaging findings. In fact, 90% of the time, we can actually make a confident diagnosis with just CAT scan, MRI, or a very sort of specialized ultrasound. And while that's been good for many people, we've kind of fallen a little bit backwards in terms of research, because we don't get the same data about the particular tumor when we're not necessarily getting a biopsy. And I think what's going to be happening in the future with personalized medicine is that we may be going back to biopsying a lot for these liver tumors, and then looking at the different receptors on the tumors and finding sort of different things on them to help us understand which medications or maybe which combined medications will be most beneficial for people when they have a diagnosis of liver cancer. So I think we're going to be moving into the forefront of personalized medicine, which I know is already the case in many other malignancies, but for liver cancer is still a little bit further behind. And then, in the last couple of minutes, I think it's important to talk a little bit about liver transplant. although liver transplant is sort of obviously a very big deal for most people, you're talking about upwards of a 4 to 6 hour surgery, sometimes longer, be in the hospital for a couple of weeks, and then having to be on medication for the rest of your life to protect that new liver. We do know that it's associated with the best outcomes for liver cancer. And in fact, we would usually quote a tumor-free survival rate of probably more than 90% if someone's able to go on to have liver transplant. So that means the tumor coming back is probably less than 10% for most people. So the reason why the outcomes are so good is because in addition to the tumor coming out, for most people who have underlying cirrhosis, the cirrhosis comes out too. And so the likelihood of the tumor coming back now that the cirrhosis is gone is dramatically reduced. While we're able to treat little tumor spots in other ways, perhaps with chemotherapy and radiation, it doesn't treat the whole liver. And we know that the whole liver, unfortunately, is prone to developing liver tumors over time in the setting of cirrhosis. And I would actually make the argument that if you look at liver transplant as purely a cancer treatment, if you look at the outcomes, it's probably the most successful cancer treatment for any intra-abdominal cancer that's out there. So if one thinks about liver transplant that way, it clearly becomes something that we're hoping to be able to offer to our patients, when people are in my situation. But not everybody is going to be a candidate for liver transplant. And in fact, there's very specific criteria in terms of the size of the tumor for who could potentially be a candidate for liver transplant. And then we have to take other things into consideration, like the patient's age and what their comorbidities are, and if they would be able to potentially tolerate the big surgery that's required for a liver transplant. And then, even just getting on the transplant list is a major Herculean effort. The listing process involves multiple tests, meeting with lots of specialists, and that's even just to get on the list. And then for many people, they'll be on the list for many months, sometimes several years before they'll even get an organ offer. During that time, one's getting regular blood work, usually getting picture tests of the liver, either with a CAT scan or MRI, every 1 to 3 months in order to make sure that if new tumor spots pop up, we're able to treat them before transplant so that there's not too much tumor in the liver before it comes out. And people are listed for liver transplant in this country based on something called the MELD score, the Model for End-Stage Liver Disease. This is a score that takes into account 4 different blood tests in order to help prioritize who should go to the top of the list for transplant. Unlike other transplants in this country, like kidney transplant, for example, how long you're on the transplant list doesn't really factor into how soon you're going to get a liver transplant. It's all based on how sick somebody is and what this MELD score is, which ranges on a score from 6 to 40, 6 being very low, meaning the liver's in pretty good shape, 40 meaning that the liver's very, very sick. And we do know that some of our patients with liver cancer, their own lab score or MELD score will be relatively low. So we get people extra points on the liver transplant list while they're waiting for their liver so that we can hopefully get them to the point of getting a surgery. And then for patients who go on to have liver transplants, there are often frequent lab draws and frequent office visits. At my hospital, people after transplant have to come to the office twice a week at the very beginning, and they're getting blood work once or twice a week as well. Then those visits decrease in frequency to the point where you may only be coming to the office once a month, then once every 3 months, and then eventually just once a year. So our hope is that people go on to, living a productive and happy life after transplant where they're not necessarily in the office the whole time. And then because the risk of liver cancer after transplant is not zero, we do also check on the new liver to make sure that there is no tumors that come back. So for the first 3 years, we typically do an MRI or CAT scan every 6 months. And then we do one every year. And then once we get to the point of 5 years out from transplant, we no longer look because the likelihood of the cancer coming back is basically zero.